Let us go back and I will ask you one question of what we have done already. Remember when we talked about the innervation of the skeletal muscle? Okay, the neuron is located somewhere in the central nervous system. It gives rise to a motor fiber. That motor fiber terminates on the skeletal muscle and releases what neurotransmitter? Very good. It will act on what kind of receptor? Yeah, the second answer was a little muted. Okay, it was nicotinic acetylcholine. What was it? Acetylcholine nicotinic type. Acetylcholine nicotinic type. Okay, all right. Then another statement that I want to make is, if you remember our yesterday's class where we talked about the autonomic supply or the sympathetic or the parasympathetic supply, in which the peculiarity was there were two neurons in the series. How many neurons in the series? Two neurons in the series. Okay. All the first neurons, I will make another general statement, all the first neurons, whether it is sympathetic or parasympathetic, are cholinergic. Are again what? Cholinergic. And like the earlier system, they are also acting on the second neuron via the nicotinic acetylcholine receptor. What did I say? So, first neuron, first of all, in sympathetic and parasympathetic, we all agree that there are two neurons in series. No doubt there, there is no dispute there. Go. Okay. The first neuron, okay, I'm making a statement now. What is it? The first neuron is what? Is what? Cholinergic. What is it? Cholinergic. What is it? Cholinergic. It is talking to the second neuron, and that second neuron is having what kind of receptors? Acetylcholine. It has to have acetylcholine receptors, again of the nicotinic type. Again of what type? Nicotinic type. So far the story is very simple. Now I am talking about the postganglionic receptor of the parasympathetic nervous system. So let us go to yesterday's image. I am not going to draw the image, but the fiber starts somewhere in the medulla oblongata. It travels over the vagus. It goes as far as the heart. It is cholinergic. It talks to the second neuron. The second neuron is very close to the heart. It talks to the second neuron via the nicotinic acetylcholine receptor. No doubt so far. The second neuron goes and talks to the heart muscle. Okay, particularly what muscle? Particularly talks to the cells of the SA node and the AV node, talks to those, and that receptor is now different kind. It is not nicotinic, not nicotinic. It is another type which is called as muscarinic. What do you call it as? Muscarinic. Now here is a very interesting point. I mean, I'll take you back to about 1930 or 32 when they knew that, well, acetylcholine is there, yes, it's there. It acts on the receptor, it's there. It acts on the receptor on the skeletal muscle, yes, on the receptors in the heart, yes, on the receptor, everywhere it acts. Okay, but then the beauty was, or the difference is where, when you take a particular drug which acts on the same receptor, but the same drug doesn't act on all the receptors. What do I mean by that? I'll go to the preganglionic fiber. Preganglionic fiber acts on the ganglion, nicotinic type. Means what? Nicotine can combine with, why am I calling that particular receptor of acetylcholine as nicotinic type? Because the molecule nicotine which I get from tobacco can act with that receptor, therefore it is nicotinic type. Then what am I am making another statement. The receptor on the heart, which again receives acetylcholine, on that receptor nicotine does not act. It does not act. Then then how do I know? I classify it because it combines with another molecule, and that molecule I get from a particular mushroom, and I call that molecule as muscarine. What do you call it as? So please remember, this is my classification of the different types of acetylcholine is not possible if I do not resort to pharmacology. You get me? See, we don't have nicotine, we don't have muscarine, we don't have them, okay? But we have the different receptors, and I am in a position to differentiate them because they interact with different molecules taken from nature. I get nicotine from nature, I get muscarine from nature. When I administer them into the rat, I find that some acetylcholine, nicotine binds to some acetylcholine receptors, nicotinic. Muscarine binds to another, muscarinic, okay? Now, having done that classification, then I want to know more about each of the type of the receptors. So, I use all the modern techniques and I want to find out what the proteins are and what are their structures, and I find that the nicotinic type of receptors essentially belong to this type of chemistry, which means there are 5 subunits. What am I talking about? Nicotinic type. What am I talking about? So, it is on the skeletal muscle, hello, skeletal muscle, it is on the plasma membrane of the cell membrane, listen to this, cell membrane of the ganglionic neuron, which is receiving the preganglionic fiber. Is it Greek and Latin? Am I making sense? Again, parasympathetic nervous system, first neuron located in the medulla oblongata. I just stated. What was the name of the nucleus? Let's see. Let's test your memory. Dorsal, vagal, motor, nucleus. Very good, very good. Every word has a meaning. Dorsal, vagal, it gives us to vagal. Okay, and it is giving rise to preganglionic fibers or postganglionic fibers. Please, preganglionic. What is it? Preganglionic. Is it cholinergic or what? Cholinergic. It's going to talk on the second neuron now. That second neuron on the plasma membrane will have what kind of receptor? Nicotinic. What is it? Nicotinic. No, I am talking about the second neuron. The second neuron is going to talk to what? Heart. Going to talk to what? Heart. Where is the receptor located? On the heart. Now, what kind of receptor? Muscarinic. Okay. So, the information is taken in the nature information taken by acetylcholine. But acetylcholine, nicotinic, acetylcholine, muscarinic. And now I am going to isolate those proteins which are of the nicotinic type, and I find that the structure is consisting of what? How many? Can you actually count how many subunits protein subunits are there? 5. Always 5. Always what? 5. And what is the and whenever acetylcholine combines with it, what do? These 5 proteins they open, okay, and then they allow the ions to pass through. Okay. Therefore, I can also call these channels as ionotropic. What did I say? Everybody, what is it? Ionotropic. Why ionotropic? Because it directly allows the ions to pass through. Ionotropic. So, I will say that whenever this receptor combines with its ligand, okay, in this particular case ligand can be a natural acetylcholine or it can be taken from outside, which is nicotine, and it can respond, and it may respond by opening the channel. It will allow the ions to pass through, and therefore I will call it as ionotropic. Done? Concept clear? Great. Now, when I go to the muscarinic type of receptor, I find that its structure is totally different. But we are aware of that kind of molecule. What are those kinds of molecule I want you to identify? They are 7 transmembrane proteins. Hello. G protein coupled. Hello. And they will take the signal inside. They will take the signal inside to the from outside to the inside. So, outside the molecule has to combine. Okay. In nature, that molecule is again acetylcholine. Okay, but it is combining with that kind of protein, acetylcholine. You can see the ACG is combining that kind of protein, and it will undergo configurational change. When it undergoes the configuration, it will act with a G protein, which may be inhibitory type or excitatory type. I will not talk about it here. And then it will take a signal. It will take a signal down into the cell, and that signal may have different paths. Either it may open a channel, it may not open a channel. It may just act on a sarcoplasmic reticulum release. There are different pathways. But since they are all metabolic, I will call that type of receptor as metabotropic. So, I will make a general statement that whereas the nicotinic type of receptor in acetylcholine is ionotropic, okay, the muscarinic type of receptor, which is a receptor for acetylcholine, is of what type? Metabotropic. Say that again. Good. Okay. So, I give here the structure of nicotine, the acetylcholine and the muscarine just for your general information. Okay, so you can read about the muscarinic type of receptor. Okay, what happens when the muscarinic type of receptor? So here is you have done an interesting experiment. You are working on a rat, you have opened the rat, you are placed an electrode, or you just look at the heart and find out how many times the heart is beating. Good. Okay, it's a rat, it's beating 250 times, no problem. Okay, then you take a pair of electrodes, you dissect out its vagus. Whose vagus? That rat's vagus. You place your electrode on the vagus and give a small current. Shock. Give a small shock. Are you with me? So, what you are doing? You are electrically exciting the vagus nerve. Okay. Along it, lot of fibers are excited. We don't worry about them. But I keep on looking at the heart and I find that the heartbeat, which was about 250 beats per minute, has come down to 200. It has come down to 150. Okay. So, what is my conclusion? That there is some information that is going from the heart. I have made a mistake, that is going from the medulla oblongata over the vagus to the heart. Okay. And when the muscarinic fibers in the muscarinic receptors in the heart are excited, heart slows down, inhibits. How does it happen? That explanation is here. It is again the same muscarinic type of receptor. You can see the plasma membrane and you can see the acetylcholine molecule combining there. What is this acetylcholine molecule coming from? It is coming from the postganglionic fiber. Hello, vagus, preganglionic, postganglionic, acetylcholine talks to the muscarinic receptor. The metabotropic, you can see the 7 times the membrane is going, the protein is going up and down, and when it does, it it gives a signal to the G protein, which is inhibitory type. There are one or more steps, then it finally talks to a channel. It's talking to the channel. What is this channel? It is the potassium ion channel. It opens the potassium ion channel. When it opens, the potassium ions go out. When they go out, the outside becomes more positive. When it goes more positive, it means now the membrane is hyperpolarized. Whenever a membrane is hyperpolarized, it is inhibited. Now, these two words we will never forget. Hyperpolarized membrane is inhibited. What did I say? Hyperpolarized. So, this plasma membrane, inside is 0. Take any membrane, inside is 0, so outside is 70. Outside is how much? 70. Maybe nerve, muscle, whatever. Outside is how much? 70. Or if I make a mistake, if I turn it other around, outside is 0. Outside is 0, the inside will be how much? Minus 70. Inside is how much? Minus 70. If minus 70 becomes minus 80, it is hyperpolarized. What is it? Remember this, it is what? Hyperpolarized means it is inhibited, it is now difficult to stimulate the cell. But from 70, if I go to 60 and 50, it is depolarized. Now, it is easy for me to stimulate the cell, inside the cell. Okay. So, don't mess up with these terms. Okay. Now, we are still looking at the same rat, and we are looking at the beats. Now, there are two traces there. One is a continuous, one is a dotted. The continuous one is the normal one, that is the control. You have not excited the vagus nerve. Okay. And then now you excite it, and what difference do you find that in the time period in which you had the 3 peaks, how many dotted peaks are you having? 2, which means what? The frequency of beats has gone down. Are you with me? I can ask a very simple question. Instead of putting my electrode on the vagus and electrically stimulate it, is it a good idea for me to take a pipette? In the pipette, take a very dilute solution of acetylcholine and directly do it on the heart. What will happen? What will happen? Yeah. Be bold. Be bold. You are permitted to make mistakes. But most logical answer, acetylcholine will combine with muscarinic receptor, and then you will have this sequence of events, and then the heart will go down. So, actually, whether you are giving acetylcholine from outside or whether you are electrically stimulating the vagus, you are ultimately doing what? You are releasing acetylcholine on the plasma membrane of the cardiac cell, and then this sequence of events which we have seen in the previous slide, and the heart will slow down. Are you okay so far? Okay, now change of gears. I am going to take you to some other aspect of the heart. Very interesting, very interesting. Okay, now let us go to the moment when the heart is not excited. Okay, what has happened? What is the position of the SA node? Not excited, not excited. SA node not excited. Just catch on to that moment. Not excited. Okay, now excited. Okay, excited means what? Suddenly there is reversal of polarity on the plasma membrane of the SM node. Rest of the heart is still, it is still not excited. Not excited. We will go very slow, although the whole thing happens within 0.345 seconds. Okay, we will go very slow. And then little later, then the action potential has spread from the SA node over the internodal pathway to the AV node. Okay, you have gone that far. Okay, or maybe you have crossed to the bundle of His. Okay. So, this part of the system or this part of the heart has undergone reversal of polarity, means what? Outside has become 0, outside of the plasma membrane was 0, now it has become plus 20. Hello, are you with me? But the rest of the heart is still polarized. So, now I want you to look at this image and try to make sense of it. This is say after 0.1 second after the SA node has excited, and you can see the negativity gone as far as the partition it has gone. You can see the partition in the right and left ventricle. You can see that there is negative, but the rest of it is still positive. As a result of some positivity there, some negativity there will be flow of current. Are you with me? There will be what? There will be flow of current within the heart. Okay. Now I can directly put the electrode on the heart and get that, try to find out how much that current is. I can do that, but for that I will have to put an electrode all the way through your skin into your heart. That's not a good idea. So, what they do now, I am going to talk about a very, very simple and a very useful pathological tool which you call as what? ECG, electrocardiogram. What did I say? Say that again. Electrocardiogram. Okay, in which what you really do is you place your electrode on your chest, and out of that current generated, whatever little comes out, Are you with me? Little comes out. You see, because it has to pass through a lot of other body parts, whatever little comes out, you pick it up and then try to plot it and try to make sense of it. Okay, that plot we will call as ECG, but this explains to you why in every cycle a current is generated, and you can pick up the current by, you can see the patient here, you can see the different electrodes, the information from the electrodes is being taken to that oscilloscope which we call as cardioscope, and then you are seeing it and you find a very interesting pattern. There is a pattern. Okay, and that pattern in standard language which has evolved in the language of by the cardiologist, we have certain waves. What do these waves represent? They represent electrical current. Where are you picking it from? From the periphery. Why is it very good? Because you are not, there is nothing invasive. Okay, you can just, I can make a lot of interpretation of your working of your heart without actually going to the heart. With the little current that I can pick up from the skin, I can plot it up and take a look at it and then try to find out whether your heart is okay or not. Okay, and then I get certain curves, and now what I am going to do another 2 minutes is try to understand what those curves really are and how do the cardiologists interpret to them. The first, there is a tiny peak there, tiny curve there, which the cardiologist will call as the P wave. What do you call it as? P wave. P wave. What do you call it as? P wave. Okay, and on the x-axis you can see the time duration taken by the P wave. Are you there with me? Okay, and on the y-axis you can see the voltage being generated every time the card goes through the circle, goes through the cycle. After that, then there is a little dip after P. Can you see it flattens, and then little dip, and then it shoots up and then again comes down. This is called as QRS complex. It is taken together. What do you call it as? QRS. This is a terminology which doctors use. I am simply trying to convey it to you. They describe the P wave, then they describe the QRS complex, and after that again there is an interval. There is an interval, and then there is what wave is there? T wave. P wave, QRS complex, and T wave. Are you with me? And in a person who is having 72 beats per minute, how much time it will take has been shown on the. So if you can just count the number of R's, there is R. Can you see Q at that R, the highest peak point of the QRS complex? So if I plot this over a minute, okay, and if I can get pulse rate of 75, I'll actually get 72 R's over a period of minute. Are you with me? This is 72 hours. It's very simple. It's 72 hours. Okay. All right. Now, please remember this, and I'll take you to another image in which we have better interpretation of the different timing. The what is the P interval? What is the PQ interval here? What is the QRS interval? ST interval? And author tells us that heart rate, the QT interval is heart rate dependent. Means if the heart rate is more, then the interval will be less. Okay. Now this is very interesting. Just focus on this. I am sure you can make out look at the image and try to draw your own conclusions. We can see the heart. You can see the heart. Okay. Then in the first image you can see the area that is near the AV node, and we are catching the moment when the AV node had just fired and the colored part there has depolarized. Are you okay? And now if you go on the lower traces there we are trying to draw the relevant ECG. So when this part of the SA node is excited and the current is spreading then you get this little rise in the P wave. Secondly, when it spreads on the, so what is the difference between the first diagram of the heart and second diagram of heart? In the second diagram of heart, the wave of depolarization has spread over both the auricles. Simple. Both the auricles, it has spread over both the auricles. When it has spread, now it has spread over both the auricles. At that moment, if I look at the trace, what do I find? P wave. What do I find? P wave. What do I find? So P wave is essentially because the two auricles are depolarizing. What is it? Are you getting the language? What does P wave represent? That then as the action potential spreads over the bundle of phase, and then it spreads over the Purkinje fibers, and it goes as far as the tip, but it has not passed over the entire ventricles. Then it goes as far as the as to the from P it has gone to Q, and then when the entire ventricles are depolarized, you get what complex? QRS complex. Are you with me? And then a little later when both the ventricles, see, they have depolarized, after a little while they will repolarize. When they repolarize, you get the T wave. You get what? You get T wave. I will explain this in the, let us take a look at. So, what have we learnt in last 5 minutes? What have we learnt? We have learnt a correlation between the cardiac cycle in which the auricles depolarize, the ventricles depolarize a little later, and the ventricles repolarize, and how this can translate into the ECG trace you can simply get by placing electrodes on the chest and getting the readings. Are you with me so far? Now, you can ask a very simple question, what about the auricular repolarization? Why do not I see it? We do not see it. We do not see it because it is there, but we do not see it because it is completely dominated by the depolarization of the ventricles. It is the QRS complex is so strong that it is somewhere in the QRS complex and we can't delineate it. Okay. Now, what is the most important use of ECG? Okay. One of the very important uses is that if there is any cardiac arrhythmia, okay, the rate at which the SA node should keep on firing on its own. Okay, if there is any problem, okay, or anywhere, or there are the interval between the two firings is not good enough, or instead of you see, the heart can go wrong in many ways. If instead of SA node, the AV node starts firing at higher sequence. So, all kinds of different arrhythmias can happen, and those arrhythmias can be detected with the help of ECG. So, what am I trying to tell you? The great importance of ECG as a simple non-invasive tool to find out whether your heart is doing okay or not. So, you can please read about the different, okay, just a few examples, you know, if the, yes.
Isn't the D wave in the negative since it is repolarization?
See, the thing is, we are not placing the electrode directly on the heart. So actually it is not a 100% representation of the cycle through which the heart is going. It is, you see, the current is going from many places, and then it is coming filtered through a system, and this is how it is represented. So it is not just the repolarization that is influencing. Many things are there. Okay, and all this is an output of all things put together. Okay, but broadly it is, but it's not possible for us to go into every. For doing that, you will have to place the electrode on the heart, and then you will get the positive, whatever positive, negative. For that, again, you go to a cell and then you place an electrode there, you will get a very clear correlation between the two. If the heart starts beating very fast, now I will introduce you to a few terms. It's called as tachycardia. What do you call it as? Tachycardia. So if the one at the top is a normal trace, the below that one is, you can see the R peaks are coming at a higher frequency. The top one is the normal. This one is the tachycardia. Okay, the lower than that is called as bradycardia. Means what? The heart is slowed down. Okay, and really interesting is on the right one. Okay, the SA node fires, fails to fire. What did I say? There is a problem in the heart, fails to fire, and then therefore, so SA node should have fired their SA block. What is Guyton trying to tell us there? SA for some reason SA just didn't fire. Okay, it doesn't mean it may fire the next time. It has not gone completely bad. Okay, so SA block is there. Okay, so these are just a few examples in which you can, and there are many examples in which you can. Okay, I'm in a rush, so I want to. Okay. We are done with the heart per se. Okay, we'll move on.